Hello, everyone. Welcome to another webinar organized by A&T Neuro Education. My name is Oksana Lalka. I'm product manager at A&T Neuro, and I'm honored to present today's webinar, tapping into the semantic frontoparietal network in brain tumor in patients, a pilot dual-site nTMS study. The webinar will be presented by Dr. Komboz, who is a medical physician and PGI 6 neurosurgery resident at Universität Medicine Göttingen in Germany. His clinical work includes preoperative language and motor mapping in eloquent glioma surgery, awake glioma surgery, intraoperative neuro monitoring, and the neuromodulation. He co-authored studies on motor evoked potentials in neurosurgery as well as neurophysiology of the insula and the somatosensory thalamus. He serves as a reviewer in journals in the field, including Clinical Neurophysiology, Neurophysiology Clinic, Frontiers in Neurology, and Central European Neurosurgery. After the scientific presentation, we will watch a relevant showcase prepared by Dr. Voyek from neurosurgical team at Lübeck. In the course of the presentation, we will raise some poll questions and appreciate your active participation. You also have the option to type your questions in the chat, and we will address them in the end of the presentation as time allows. So, Dr. Komboz, once again, we do appreciate you accepting our invitation, and without further ado, we are all ears to listen to your presentation on how we can target the semantic frontoparietal network with the navigated TMS. Please.
Thank you, Oksana, for the kind introduction. Thank you everyone for joining today. It's my pleasure to be presenting this. Thank you also to the A&T Neuro team for the opportunity to present this work here today. I'll be talking about the semantic frontoparietal network and its cortical organization, especially in brain tumor patients, and I'll be talking about a research project of ours in Göttingen, Germany, where we try to optimize the mapping of this network in brain tumor patients. Before we get into a little bit more detail, it's always important to mention that we are resting on the shoulders of giants, and it is important to acknowledge the first model of language organization in the brain, which emerged in the 1860s from doctors Broca and Wernicke. And I wanted to mention this for two main reasons. The first, as I said, this is the first real representation of cortical or language networks ever to be described, and this served as a hallmark model for our understanding of language organization for a very long time, and it laid the foundation for our current understanding of language organization at the cortical level. That's the good thing. Unfortunately, up until today, this is still the most taught language model in medical schools till today. And even if this model is extremely elegant and intuitive, it does not really represent our current understanding of cortical representation of language anymore. You know, in the last 160 years, so it started with Broca, Wernicke, and the arcuate fasciculus connecting both areas. But in the last 160 years, we did some progress, and we had CT, and then we had MRI, and then we had functional imaging and non-invasive and invasive brain stimulation, which led to much more accurate and complex models. First. Second, the Broca-Wernicke model does not explain all kinds of language deficits that we see in patients with dysphasias and aphasias. And third, I wanted to show this picture from a study done by the group of Nina Dronkers in 2007. Professor Dronkers was able to scan the brain of the patients from Dr. Broca, which are still conserved, and she put them in CTs and MRIs. And here you can see the brain of the patient, Monsieur Le Bon, which had a so-called Broca aphasia with a lesion of the Broca area. And now that we have more detailed imaging of the brain of this very particular patient of Dr. Broca, we can see here that the lesion that the patient had was not contained to the classical Broca's area, but rather it involved large regions of the cortex, of the subcortical white matter, even getting to the basal ganglia. So all of these reasons make this model not up to the current current understanding of cortical language organization that we now have. And the current model looks a little bit like this, at least in neurosurgery, because with the advent of pen-field stimulation and stimulation during awake surgery, neurosurgeons started performing more and more direct electrical stimulation of the cortex using pen-field stimulation, and realized that the language network is much more extended across the frontal lobe, the parietal lobe, and the temporal lobe, as you can see here. This is a meta-analysis, and at the subcortical level, it's not just the arcuate fasciculus anymore. There are many more white matter pathways that are involved, as you can see here, and they're divided in two main streams. And this is the current model that we are using, which is a dual stream language model, which is basically composed of the dorsal stream, the arcuate fasciculus, and the superior longitudinal fasciculi, which are more involved in the phonological processing of language, versus the ventral stream, composed of the inferior front-occipital fasciculus and the uncinate fasciculus, which are more involved in semantic processing. This is, of course, still a very reductionist view. It's a little bit more complex than that, but for the sake of time and for today, we will stick to this at the subcortical level. We will take a look at the semantic cortical network more into detail. Now, if you want to break down this scattered extended network of the language eloquent areas of the brain to the areas that are more common, more constant across patients, and whose functions are also more constant across patients. To break this down very roughly, and I'm omitting a lot of things here, but to get to the point of the research project that I will describe later, we can roughly break this down to some of the points that you can see here. You can see here the aIFG divided in its anterior part in red, the anterior aIFG, which is more involved in semantic processing. The posterior aIFG more involved in phonological processing. This is at the frontal level. At the parietal level, at the level of the inferior parietal lobule, you have the supramarginal gyrus that is more involved in phonological processing. The angular gyrus more involved in semantic processing. And across the temporal lobe, you have different regions that are involved in semantic hub functions, like the anterior temporal lobe. but also acoustic phonological analysis, word forming, etc., etc. That where I will not go into detail today. We're going to take a further look at the frontoparietal network today, composed of the areas I just mentioned, and the semantic part of it. So the anterior frontal gyrus here in red, and the angular gyrus, which are considered key nodes of this semantic frontoparietal network. And these two areas communicate a lot with each other, which raises the question: is there some sort of redundancy in this semantic network due to the communication of these two regions? And I will get back to this right away. Now, what methods do we have in neurosurgery to map the cortex of patients, especially those patients who have brain tumors located in language-eloquent areas, and we want to remove the tumor while maximizing the resection while minimizing post-operative language deficits. So as I said before, we have the direct electrical stimulation. So in the awake setting, we operate the patients awake. We expose the cortex, and with a bipolar electrode, as you can see here, we place this bipolar electrode on the cortical surface on these different points, as you can see here, and then you can map. You can deliver a current at any given point of the cortex, and when the patient is doing, for example, a language task like naming, counting, reading, writing, during the stimulation, you can basically induce a virtual lesion for a couple of seconds and see if the task that the patient is doing is getting altered by the stimulation. And this is the gold standard, and this is still today the gold standard for identifying language-eloquent cortex. And based on the results of this stimulation during surgery, we guide our resection and make decisions based on the fact that, or based on whether the stimulated areas induce deficits or not. If they induce deficits, they are marked as language-eloquent and they are preserved. If not, they can be resected. DES, direct electrical stimulation, gives us a, as I said, it has a very high accuracy, gives us very good results, and allows us to maximize the resection while minimizing post-operative deficits. And using this, we can see, for example, in patients with slow-growing tumors, that language areas often shift in these patients from an area that is usually related to language. And now that the tumor is slowly growing in this area, we can see that with neuroplasticity, language-eloquent areas often shift to other places that we cannot predict before, and then we can only map in this setting. The same with left-handed patients, bilingual, trilingual patients. We can see atypical distributions of cortical language organization. Now, DES is great, but DES still has some limitations. It demands awake cooperative patients who are able to cooperate during an awake surgery. We need patients with good respiratory system, because patients with, for example, obstructive lung diseases are very difficult to monitor during awake surgery, because they sometimes really have difficulty with their airways, so that mapping during awake surgery can be very limited and sometimes not possible. Patients with anxiety who cannot tolerate the awake settings, and also the time limit that we have during surgery. So you cannot keep a patient awake for many hours and expect them to deliver all the time with a very high efficacy while you are doing many kind of different language tasks. So you have to break it down to the most essential part during the surgery, and you cannot test everything. You have to be fast and efficient and delineate functional cortex from non-functional cortex. So for all of these reasons, there is a need for non-invasive preoperative mapping techniques that can more or less predict language-eloquent sites before the surgery, to allow surgery planning and to allow surgery in patients where awake surgery is not an option. So what options do we have? We have functional MRI. We use it very often at our center. And with task-based fMRI, where patients are performing tasks like naming, verb generation, recognizing real words from pseudo words, you can reconstruct whole brain activation maps, and then see which areas are involved in language processing. This is very useful for language lateralization between the left and right hemisphere, and it also shows us the sites that are involved in affecting whatever tasks the patient is doing. But these maps show us basically all of the regions that are more or less involved in the processing of this particular task, but not necessarily the areas that are indispensable for this activity. So all of the regions you can see here have something to do with verb generation, but it doesn't mean that the resection of some of these areas would lead postoperatively to verb generation problems. So fMRI still has a relatively low positive predictive values when it comes to determining really the most essential voxels of the cortex that you want to resect or preserve. So it does not replace the EES in this matter. What we also use in Göttingen is navigated TMS, which is the topic of today. Transcranial magnetic stimulation, in short, induces an electric field non-invasively by applying a magnetic coil to the head surface, and via a rapidly changing magnetic field, one can induce neuron depolarization at a very focal area of the brain surface. And when you combine this technique with frameless neuronavigation, you can basically see on the screen in real time which specific area of the cortex you are stimulating. And with newer systems using E-field, you can also take a look at the spread of the current across the cortical surface, corrected to the skin and to the bone. So basically, how the magnetic field will stimulate the cortex after we correct for inaccuracies due to the overlying skin and bone. We use navigated TMS for motor mapping, so mapping of the motor cortex, mapping of the motor essential functions in patients with motor eloquent tumors. And TMS for motor mapping has a very high sensitivity and specificity, really approaching 100%, and this has been shown in many studies. It has a very high concordance rate with intraoperative DES. For language mapping, the performance is increasing across the studies. The results are still variable between centers, but still, all in all, the results are a bit less concordant with DES than for motor mapping. So we often have high sensitivity but bit poorer specificity, and there is still a need for improved paradigms for TMS language mapping. Based on this, and based on the frontoparietal network that I described to you earlier, we were inspired by a study by Professor Hartwigsen, who analyzed in healthy individuals the frontoparietal network and performed a TMS study, where she showed that in the two core semantic nodes of the frontoparietal semantic network, if you apply TMS to one of both areas, healthy participants will compensate while performing language relevant tasks, whereas conditioning one node and stimulating the others, so a dual site stimulation of both core semantic nodes, will lead to significantly increased reaction times in language tasks in healthy participants. And we try to apply this protocol to brain tumor patients and use this protocol to perform preoperative language mapping in patients with language-eloquent brain tumors located in one of these two core semantic nodes, with the aim to evaluate the added value of this so-called condition-and-perturb approach to the standard preoperative nTMS language mapping. This was a prospective pilot study. The inclusion and exclusion criteria were very strict. Right-handed patients with a tumor growing in the anterior aIFG or the AG, so in the language-eloquent area, but still patients who did not have severe aphasias. Other exclusion criteria were refractory epilepsy and contraindication to TMS and awake surgery, since these patients were scheduled to undergo awake surgery. So these patients underwent MRI, our workflow with functional MRI, as I showed earlier, and then they underwent navigated TMS preoperatively with language mapping. We evaluated language mapping with an object naming task. We performed standard nTMS language mapping. So basically, the TMS protocol is divided in two. The online stimulation, which is basically the stimulation we perform when the patients are performing the object naming task during the stimulation. And the offline stimulation is the stimulation we perform, the preconditioning that we perform before this online stimulation. And the patients underwent two sessions. One online session preceded by a sham offline preconditioning session. The second session was online TMS over the tumor affected area, preceded by repetitive TMS over the ipsilateral healthy node. So basically, if the patient had a tumor in their angular gyrus, we performed online TMS mapping over the angular gyrus after we performed offline preconditioning of the anterior aIFG. We exported these data into our Neuro navigation system. We performed awake surgery, and we validated the results with the intraoperative findings. So patients underwent direct electrical stimulation during the surgery, where we mapped the language-eloquent hotspots, and we evaluated afterwards how these hotspots overlapped with the hotspots we collected from standard nTMS mapping and nTMS mapping after the CAP, so Condition-and-Perturb protocol. We included so far 8 patients with different types of brain tumors, 5 of them in the angular gyrus, and 3 of them in the anterior aIFG. All of these patients received fMRI, and all of these patients had significant activation in their left aIFG and angular gyri while performing language tasks. In these, from these 8 patients, 5 of them had basically cortical hotspots that could be elicited during awake surgery and during preoperative TMS. 3 patients had a negative TMS mapping and negative DES mapping during awake surgery. Now, taking a look at these 5 patients, so patients with positive intraoperative mapping during awake surgery, of these 5 patients, we could map 4 of them using the standard preoperative nTMS protocol. When we added the condition-and-perturb approach, we could also elicit language errors, so map language hotspots in all of the 5 patients before surgery. We were able to increase the error rate, and we were able to increase the positive and negative predictive values after preconditioning the healthy node. As you can see here in this schematic version, here you have the DES hotspots, and here you have in blue the standard mapping, and then when you add the condition-and-perturb, you can elicit all of these errors plus additional errors. And what we also do is we usually use these TMS hotspots as seeding regions for tryptography. And when you take, for example, here, as you can see at the bottom right, this language hotspot next to the brain tumor and the inferior parietal lobule, this hotspot could be only elicited after preconditioning the aIFG, but not during the standard TMS protocol. When we took this hotspot and used it as a seeding region, we could in an exemplary fashion reestablish the connectivity between the frontoparietal semantic network, just as an interesting example to be shown here. So this condition-and-perturb approach is, to our knowledge, being used for the first time in patients with language-eloquent brain tumors in a dual-site TMS study setting, and we were able in this patient group to really see that frontoparietal network disruption seemed to sensitize the semantic network and allow us a better, more accurate hotspot detection during preoperative nTMS. And this protocol seems to enhance the sensitivity and specificity of the whole protocol. Of course, the number of patients is very restricted, mostly due to the very strict inclusion criteria, but we are still recruiting, and we are looking to enlarge the database to a multicentric on a multicentric fashion. So if you're interested, if your centers are interested, please reach out. Some centers have already reached out, and we are already starting to plan the multicentric protocol. Before I take your question, I would like to thank all of the collaborators in this study, Andrea Antal from the NIBS lab, Roberto from the SNP lab from psychiatry, and Nicole Neve from neuroradiology, who performed the beautiful fMRI reconstructions that you saw earlier. Thank you for your attention, and I look forward to your questions.
Thank you, Dr. Komboz, for your brilliant and enlightening presentation. And thank you for sharing your insights on the role of nTMS in mapping the language network in the brain tumor patient.